So welcome everyone to our breakout session on quality improvement collaboratives. We're going to break down a little bit on what is a quality improvement collaborative, why do we do quality improvement collaboratives, kind of our purpose behind that. And then we'll go over a few of our previous quality improvement collaboratives. We have an idea of kind of what those were and how they've morphed into what we call community of practices. I'll go through what that is here in a minute. And then show you what's on the horizon and sort of give you a broad overview of many of the exciting collaboratives that we have upcoming over the next few years. So with that, let's jump in. As I think many of you know, the EMS for Children program's mission is to reduce childhood morbidity and mortality due to severe illness or trauma across the care continuum. So starting with the emergency response through pre-hospital care, hospital care, transfer to specialty care, rehab, and then on return home, education and prevention. Now, the EIIC's mission is very similar, and that is to accelerate improvements in the quality of care and outcomes for children who are in need of emergency care. So there's two kind of key words in our mission statement that I want to draw your attention to, and the first one being quality. And while I think maybe a lot of us have a good understanding of what quality is, what quality can mean, how do you define quality and how do you measure it in healthcare? And so the IOM came up with 6 different domains of quality, and that is safe, effective, patient-centered, timely, efficient, and equitable. So these are the 6 measures by which we really define quality, and especially in our quality improvement collaboratives. So safe being, how do you avoid injuries to patients resulting from the care? Effective meaning, are you providing services that are based on scientific knowledge, making sure that everyone can benefit? Patient-centered, ensuring that the patient is in the middle of everything you do, that it's respectful of the individual patient, their needs, their values, ensuring that all the clinical decisions are really made around the patient. Timely, reducing waits, harmful delays. Efficient, so avoiding waste, supplies, ideas, energy, not duplicating efforts. And equitable. And we've had some very fantastic talks over the past couple of days on our EDI efforts within the EIIC, and making sure that everything we do, especially around our quality improvement collaboratives, takes in sort of these EDI principles. So the other key word in our mission statement is accelerate improvements in quality. So how do we do that? And for us, that is quality improvement methodology. So quality improvement methodology is quickly becoming sort of the foundation for improving healthcare across the spectrum. There's a lot of efforts around cost of care, patient satisfaction, patient safety. I think a lot of certifications, board certifications, you have to do some quality improvement work at this point for many of the specialties. So you're involved in quality improvement. But really, why is this so important? And that is sort of, we know that the reliance on this passive dissemination and uptake of evidence-based practices to the clinical environment can take 10, 15 years, sometimes longer. And quality improvement methodology can really accelerate this uptake more rapidly, improve care. We're talking on the order of maybe 3 to 5 years. So what is quality improvement methodology? Now, HRSA defines quality improvement methodology as quality improvement consists of systematic and continuous actions that lead to measurable improvement in healthcare services and the health status of targeted patient groups. Now at the EIIC, we changed this slightly, and that is really that for us, quality improvement consists of systematic and continuous actions that lead to measurable improvement in healthcare systems. And so some of you might be sort of familiar with this idea that every system is perfectly designed to get the results it gets. It's commonly attributed to one of the fathers of quality improvement, Edward Deming. And really, so the idea being that our quality improvement collaboratives don't necessarily focus on a single disease process or a single care process, but we work on strategies that improve the larger system as a whole. And I want to emphasize that, we support rapid transformation in care with a focus on both EMSC grantees as well as our frontline providers. And so we're really working with the goal of supporting the priorities of the larger EMSC system, so our performance measures, working both at the level of the grantees, but as well as in our EMS agencies and our EDs and our hospitals and all across the continuum of care. So how do we do this? And our work at the EIIC is based on the model for improvement. And what this is a relatively simple framework that we use to drive improvement. And it begins with 3 questions. What are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in improvement? So this first one, what are we trying to accomplish? We will set what we call aim statements or SMART aims and really identify, really specify what we are trying to change. What are we trying to improve? And then the second one can be a little bit more complex, and is that how will we know that a change is an improvement? And that is we work with all of our participants on conducting a baseline environmental scan, really understanding where they are beginning with, and then to use some data and measurements, and I will talk about how we look at measurement here in a few slides, but to really understand how you know that a change that you're implementing results in improvement. And then finally, what changes can you make that will result in an improvement? And we work with a range of subject matter experts. I will go through that in the next couple of slides on how we really identify those change strategies and those drivers to drive improvement in a certain area. And then we progress to what we call PDSA cycles or plan, do, study, act cycles, where you implement the small test of change, analyze it, and decide whether you want to continue with that change, add another one. How close did that get you to your aim statement or to that question up above? So that's maybe a very quick and dirty version of quality improvement methodology. The Institute for Healthcare Improvement has a fantastic amount of resources if you want to learn more about QI methodology. We also teach it throughout all of our collaboratives. And so we always encourage, of course, everyone to join our collaboratives and our quality improvement methodology. But IHI, they have a fantastic YouTube channel, much more on QI methodology from them. So what I really want to shift here to is, so that's quality improvement methodology. So what is a QI collaborative? And the way we've really kind of envisioned this is the how of pediatric readiness, right? So we have, and you all are, I think, very familiar with this, we have the checklist and we have the toolkits and the assessments, both on the hospital and the pre-hospital side now. And that I kind of see as the what, but our collaboratives are really around how. How do you implement this into clinical practice? And so we bring together a wide range of expertise from, people who know, subject matter experts who know the evidence, who know the area, who know the field. We also bring in people who know quality improvement methodology, project managers, IT infrastructure, data and analytics. And then we bring these experts together and really select a topic and really identify improvement strategies and design the content. But the real crux of our QI collaboratives is just that, the element of collaboration, where we bring people from around the country, or even in the case of the PEC Workforce Development Collaborative, around the globe, who are all interested in a topic. And the idea is to exchange ideas, troubleshoot challenges, and sort of collectively improve.
9 a.m. Jesus Christ.
There's someone who's not muted. If you could please mute yourself, that would be great. Okay, so digging into that a little deeper, what does a QI collaborative look like? So I talked about how we really evaluate the evidence base. We bring together these multidisciplinary teams from different settings, design the content, we bring experts in. So that's really this first area. I'm not sure if you guys can see my cursor, but this first area. And then we go out and we enroll participants. And the way the collaborative really works is that we have a series of virtual learning sessions interspersed by PDSA cycles, or where our collaborative participants are doing the actual work. And so the idea behind these learning sessions is that they can receive support from our content experts, really promote that shared learning, that collaborative improvement, that collective exchange of ideas, as well as, and we are getting more and more robust in this angle, is this data-driven feedback, where we have dashboards, for instance, in our PRQC collaborative, which you'll hear about in a little bit, where we had these really fantastic data dashboards that as our participants entered patient data from their charts, they could chart how and see how they improved over time with each change strategy. So key elements of an improvement effort. So if you are a participant in one of our QI collaboratives, what are you going to learn? What are you going to do? First is you're going to set an aim, a SMART aim. And we go into a little bit more about what's a SMART aim, how do you set up a SMART aim so that it really encompasses everything that you want to achieve. And then we go through building a team. Who should you grab to help you within your ED or your EMS agency or within your EMS program to really support this effort. And then, as I talked about on the previous slide, conducting sort of this baseline assessment, or what we call an environmental scan, to really understand where you're starting, set some benchmarking data, and then work through those drivers and change strategies, and making sure that you're measuring your efforts, ensuring that the change that they implement is really having an impact. Touching again on our learning sessions, really about the collaborative aspect. So overcoming barriers, talking about measurement and improvement over time, and really sharing ideas around sustainability. So I'm going to take just a few slides here and kind of talk about our approach to measurement, data, and analytics, because I think this is really the crux of a QI collaborative, as Peter Drucker is famous for saying, if you can't measure it, you can't improve it. Although I heard that this quote is misquoted many times. So the idiom, I guess I'd say another idiom in QI methodology is, if you can't measure it, you can't improve it. So we use it on a beating framework for measurement. It's really a conceptual model that provides a framework for examining healthcare services and evaluating the quality of healthcare. And so you can look at structural measures, process measures, and outcome measures. Structural measures are really, I think, maybe sort of the low-hanging fruit. So it's like, do you have the equipment? Do you have the staff? Is everything in place to really drive improvement? That's the foundation. And then processes of care. So this involves every aspect of kind of the interaction with the patient. What does that process look like? Is there protocols written that really kind of improve the quality there? And then outcome measures. And that's when we start to look at maybe morbidity, mortality, some of these other more definitive outcome measures. And so kind of taking that into a little bit more depth here to look at our measures. As you'll see here, moving across kind of from left to right, our structural process outcome measures, but there's two additional ones that I want to talk about. That is quality of life and functional outcomes. So I'm going to use sort of our telehealth collaborative example as to give you kind of an idea of what sort of these measures would look like. So a structural measure, as I mentioned on the previous slide, is the context for care delivery. So staff, buildings, finance, equipment. So an example would be that making sure that there's a telehealth card in each of your participating EDs. Process would be the transactions between the patients and the providers throughout the healthcare delivery. So example being a checklist that demonstrates all aspects of the telehealth visit were addressed. Outcome, really kind of the effects of the change on the patient's health, behavior, knowledge, satisfaction. So the example here being, perhaps the number of hospitalizations decrease for the telehealth cohort versus the baseline, or that sample size that you didn't use your telehealth intervention with. And then these other two, which we will admittedly have not touched much on in our collaboratives yet, although we would very much like to in the near future, and that is quality of life. And this is going beyond morbidity and mortality. It's really patient satisfaction or their family. They really have high quality of life. And then functional outcomes. And this is kind of married there with quality of life. Are they able to have the same behaviors and skills allow them to achieve everything? So the example here being the PEDS call survey, a better school experience, social integration during the pandemic. And so, we try to, when we design a quality improvement collaborative, to identify measures that kind of go across this entire spectrum. I would say in more of our recent or past collaboratives, it's been more about structural and process measures, but slowly looking more at those outcome and quality of life and functional outcomes. So a quick aside right here before I turn it over to Dr. Kate Remick to talk about some of our previous QI collaboratives is just to break down kind of our three different collaboratives that you'll hear us talk about. And what I've talked about a lot is this middle one, this QI collaborative, and that's really where we're implementing the known best practices. We're utilizing existing resources, the guidelines, the checklists, the toolkits, everything that's kind of already established. And we're identifying the most effective change strategies to implement that into clinical practice. Now, if we take a step back and we go to the left hand of the slide here, that's our learning collaboratives. And really the idea behind our learning collaboratives is that maybe the evidence base is not so strong, or maybe the resources and the tools are not as readily available. And so a learning collaborative is about identifying these best practices, mapping out key drivers, developing the resources. They're more, I'd say, exploratory in nature. And then if we move to the far right-hand side of the slide, that is our community of practices. And so those typically follow a QI collaborative, and they're maybe less intense. The meetings maybe happen quarterly versus monthly. And the focus is really on sustainability and spread. So how can we take the most effective change strategies that we identified in the QI collaborative and ensure that they are reaching more people in more states? How do we build upon that foundation, add more resources, continue to develop best practices, and continue to support those who are trying to implement these changes? So before we shift, I guess, into some of our previous EIIC QI collaboratives and what those looked like, are there any questions on our approaches to QI collaborative, or really what we mean by a QI collaborative? Okay, and with that, I will turn it over to Dr. Remick.
Great, thank you so much, Meredith. If you could go to the next slide. I just want to emphasize that the work that we're trying to do is about really transforming systems of care, of which there is quite a lot of diversity across our country. And you just heard Dr. Fallett talk about even the development of trauma centers that have been in place for over 50 years now, and there's such diversity there. That one of the biggest challenges with our collaboratives at a national scale is that we're trying to make sure that they're both tangible, but also relevant to the work that's being done by everybody on the ground, regardless of their geographic location or resources within their emergency care system. So we're just going to walk through some of the previous quality improvement collaboratives that we've launched over the last 4-5 years now, starting with our facility recognition collaborative, moving into the PEC learning collaborative, briefly mention PRQC and our disaster and telehealth collaboratives. And then we'll spend the last bit of time just talking about what is on the horizon in terms of our quality improvement activities. So if you jump to the next slide, please. So this is just kind of an overview of some of the structural components of our quality improvement collaboratives so that you have a better understanding of where all those linkages are. As you heard Meredith give an overview of the elements in terms of project management and analytics and the like, one of the core components is really being able to align our priorities in the work with our national stakeholder groups. And you'll see that each of our quality improvement collaboratives are supported by a steering committee or an advisory committee that really includes or comprises representation from all of our national professional partners, as well as other stakeholder entities. And this is sometimes variable depending on our area of focus. But at minimum, there's always some advisory group that helps us with our alignment. We've also worked hard to really include families and the voice of families in our advisory councils, because these are the individuals, for whom we're really trying to improve our emergency care systems. In the Facility Recognition Collaborative, we had 14 total states, and you can see them listed here. And in this collaborative, it was really a high-level approach, because each of the teams worked collaboratively to actually develop the content that they were going to be pushed out. In many of our quality improvement collaboratives, the best practices already exist. We've pulled those from our learning collaboratives. We've pulled those from actual activity within the field. But in this particular one, really developing a state-level recognition program for pediatric emergency care was something that most hadn't had experience with. And so this was really divided among 3 work groups: an education work group, an analytics work group, and an intervention work group. You'll see the same structure among some of our higher level clinical collaboratives in the American Academy of Pediatrics and others. The other piece that was really important about these quality improvement collaboratives is that we have content coaches. And in this particular case, we also had the presence of quality improvement specialists that helped to guide some of the work we did in terms of using quality improvement tools such as stakeholder grids or key driver diagrams and the like. Next slide. So as we approached the Pediatric Facility Recognition Collaborative, we really wanted to help support the states so that we could measure improvement over time. And as you can imagine, to implement a statewide program is not going to happen overnight. This takes many months of garnering support from stakeholder groups and establishing a plan. And so these were our 5 phases that we really established to be able to work through this effort. The first was really just getting a baseline scan of the current state of pediatric emergency care and recognition. The research phase was really focused on how are these sorts of programs developed within a particular state or territory to understand where the possible drivers might be and or change strategies might exist to be able to make improvements. The stakeholder agreement was really bringing together stakeholders across the state or territory to say, we believe in this conceptually, that pediatric medical recognition is important. We get behind that and we're willing to support your efforts to do so. And then the implementation plan and piloting and launch of that project, which in many cases during these 12 to 18 month long collaboratives, which is our typical time frame, for something at this scale at a state level, they may not actually be able to get to the implementation phase in that short time frame, because we know in many states it took 10+ years to actually develop pediatric medical recognition programs, but it still provided us with a snapshot of where improvement was being made. If you go to the next slide, please. So this is an example of the states that already had pediatric medical recognition programs before we started. That's on the left-hand side. And then we added in these 14 states to begin this work on the pediatric facility recognition. You can see those highlighted in blue. If you go to the next slide, over the course of the 12 to 18 months, you'll see that each of these states really made amazing strides in being able to achieve their goals. Not every state, of course, got into the phases of actual implementation, although many did. And it was just impressive to see that level of growth. But more importantly, during these collaborative sessions, they learned so much from each other. Next slide. As Meredith mentioned, our quality improvement collaboratives typically then move into a community practice. That's been ongoing now for the last couple of years. And because of that, there's been ongoing efforts to integrate or develop these pediatric medical recognition or pediatric readiness criteria into state programs. And so that transitioned, and you can see now, if you go to the next slide, that we are currently 17 states. Next slide, please. That have pediatric readiness recognition programs in place. And those are listed here. Some are more robust than others. Some have been present for many, many years. Others are really just fresh and starting out and may have only recognized a few hospitals, but now there are over 100+ hospitals in the country that have been recognized through these programs. Next. The second collaborative that was undertaken was the Pediatric Emergency Care Coordinator Learning Collaborative. And again, this was a learning collaborative because the goal was, how can we best develop recruitment strategies to designate individuals within EMS agencies to serve in this role? This was led by some really fantastic content experts, Sam Vance being one who's on this call, Mark Auerbach as well, who's also listening, and several other content experts across the EMSC community. In this particular collaborative, they brought in 9 states that represented collectively about 10% of EMS agencies across the country. And the goal was really to develop these strategies to recruit and sustain pediatric emergency care coordinators within EMS agencies. At baseline, there were only about 23% of agencies that had reported the presence of a PEC. Go to the next slide, please. These were the states that were engaged in that. And the aim was that in a very short time period, this was approximately a 6-month collaborative, that these 9 participating states would have established pediatric emergency care coordinators in over 50% of their EMS agencies. So pretty lofty goal for a short period of time. If you go to the next slide, you'll see that working through these processes and working in collaboration, they started with 13 new PECs and were able to achieve 525 new pediatric emergency care coordinators across these states. So really just an amazing level of improvement and engagement and strategies that were developed out of this collaborative. Next slide. Because of this work, they not only exceeded their goal, but you can see that on a national level now, the number of pediatric emergency care coordinators within EMS agencies improved from 23% to 30%. And we continue to grow this number as we kick off the PEC Workforce Development Collaborative here in just a few minutes. Next slide. The Pediatric Readiness Quality Collaborative is our next quality improvement collaborative. This was a pretty heavy lift and required a lot of coordination with our sister center at the National EMSC Data Analysis and Resource Center. And the goal of this was really a grassroots approach to improving pediatric readiness, as opposed to more of the top-down approach that you just heard about with the Facility Recognition Collaborative. We enrolled approximately 130 emergency departments across 17 states, and you can see those highlighted here in blue. And the focus was to help them identify someone to serve as a champion, oftentimes multiple people who really served as a team, because we know that having a pediatric champion makes such a huge difference in pediatric readiness overall. The second goal was to allow them or provide them with resources, support them with resources to be able to integrate specific pediatric readiness efforts into practice. And we focused on 4 critical areas that had been noted gaps in the 2013 assessment: weighing children in kilos, identifying early identification and intervention in children with abnormal vital signs, optimizing interfacility transfers, and then the last, which was disaster planning, which was a bit more exploratory and felt more like a learning collaborative for those that were engaged in this, and we'll talk a little bit more about that. But these hospitals that were engaged, they chose any of the, please go to the next slide, thanks Meredith. The hospitals that were engaged chose any of these 4 areas of focus, and the goal was to train them in some basics of quality improvement, implement strategies, and be able to actually measure their improvement over time at the patient level, as opposed to at the state level or at even the hospital level. So in this particular collaborative, they were looking back at patient records to be able to monitor key variables and key quality measures to look for improvement relative to those 4 bundles. Next slide, please. This was the basic approach, as we created essentially teams that involved a training site that was essentially a comprehensive medical center that saw at least 10,000 or more children per year, and then a group of affiliate sites that work collaboratively with that training site to implement best practices based on the regional challenges that they were facing. Go to the next slide. And this is an example of the dashboards, the quality dashboards that were available to each of the participating sites. They had both their individual site level dashboard as well as aggregate dashboards so that they could benchmark their performance with other sites that were participating in the overall collaborative. And over time, they were able to measure and see improvements in the way that children were actually being treated in their particular institution or organization. Next slide. I'll turn it back to Meredith.
Thank you. With that, I'm going to talk briefly about our Pediatric Disaster Preparedness Quality Collaborative. And this one really came out of the PRQC. And one of our major lessons learned from the PRQC Collaborative was that the disaster bundle was maybe a little bit of a round peg in a square hole for the PRQC, and that it was maybe slightly different in nature and really kind of difficult to incorporate with some of the other activities we were doing at PRQC. So we pulled it out as its own collaborative, and we hosted this in collaboration with the ASPR-funded Eastern Great Lakes Pediatric Disaster Care Center of Excellence. And really our aim with this disaster collaborative was to enhance the ability of hospitals to receive and treat children in response to a disaster. So we had 3 different specific aims, each focused on a different kind of section of the collaborative. It occurred in 3 phases, and the first one being on internal pediatric disaster preparedness, so making sure that your own hospital has had their own plan to include pediatric specific needs. Specific aim 2 was interaction with sort of these regional disaster coalition building, and what partners in your region can you really identify to meet the needs of children. And then third aim, having that baseline established within your own hospital and really establishing really robust partnerships within your region, starting to tackle some of these key elements of pediatric disaster preparedness, one being patient tracking and reunification. And so we really worked with them on moving through how to develop a pediatric patient tracking and reunification plan. I think if I go to my next, I'll show you on the next slide. I'm going to jump to this one and then jump back. And how do you really put that together and make sure you include all these essential elements? And the idea being here that we would take pediatric patient tracking and reunification, but teaching them a process on how you take your disaster plan, identify the elements that need improvement, work with your team to implement those improvements in a specific area. So not biting off a whole pediatric disaster preparedness, but really working on specific small areas. And it's kind of true to this QI nature where we're not going to try to go out and make these ginormous changes, but really take a small change, patient tracking, can you improve there? And then if you learn that process and they learn how they can improve in that area, using kind of what you've learned from our first internal coordination section and then the regional coalition building to move on to other areas of pediatric disaster care, such as triage or decon or really interfacility transfer. And we kind of let them set the stage to do that more on their own. And as we move into more of our disaster collaboratives that you'll hear towards the end of this talk on how we really are going to support pediatric champions around the country who are working to do this at their institutions. We also hosted this bonus tabletop exercise. It was a request by our participants actually to test their patient tracking and reunification plans. And so this was a 3-hour virtual tabletop exercise that we designed with hospitals from both the collaborative, as well as had several hospitals that weren't part of the collaborative, but very interested in participating. Join the virtual exercise. It didn't have a huge educational component to it because we had moved through the whole collaborative. And so it was really about presenting them with a situation. And then each hospital had their own breakout room, which they would go into after each inject and really discuss the inject, discuss what they were going to do. But then come back to the main room and exchange those ideas. And we heard from lots of our participants on how wonderful it was to hear ideas about how different hospitals were approaching this all around the country. It was fantastically successful, and we plan to do it each year moving forward. So just a quick snapshot on what these participants looked like. Mainly, we at first focused our recruitment in the Eastern Great Lakes area, which is why you kind of see a lot of these states, a lot of their states and their numbers around the Eastern Great Lakes area, but then ended up opening the collaborative to countrywide. So we had participants from California and Washington and even Puerto Rico. And so wide range of hospital types from satellite emergency departments all the way through children's hospitals and academic medical centers, and a wide range of pediatric volumes as well. And so with that, I'm going to turn it over to Lisa to talk about the Telehealth Collaborative.
Thank you, Meredith. So we just actually wrapped up on June 30th, our Telehealth Collaborative. So what do we know? We know that during, especially during the beginning phases of the pandemic, of the COVID-19 pandemic, emergency departments were seeing as much as a 70% decrease in visits for children under the age of 14. So suggesting that there were serious gaps in access to much needed care, specifically for children and youth with special health care needs and children with behavioral health emergencies. So we, the EIIC had an opportunity, a wonderful opportunity to kick off a telehealth collaborative. So we started, we kicked off in January of 2021, and you'll see on your screen here our SMART aim. By June 30th of 2021, we'll have 100% of participating states and territories. Will increase by 25% the number of pediatric healthcare providers who are ready and able to provide emergency telehealth services for the targeted population. So in addition, yes, we encompassed, the target was children and youth with special healthcare needs and behavioral health emergencies. However, we really wanted to focus on children in rural areas, Indian health services, and so on. Next slide, please, Meredith. So the different phases of our collaborative, each team started out by doing an environmental scan, establishing a baseline and identifying gaps. We moved on to strategic planning and formalizing a plan to address gaps, and then moving on to implementation, really addressing those gaps using the QI methodology that Meredith mentioned earlier in her presentation. Next slide, please. So you'll see on your screen, we had a nice a really nice distribution of our HRSA regions. We had 8 state teams and territories who participated, excuse me. And those teams were very diverse. Most of the teams were in very different phases of either thinking about implementing a telehealth plan or a telehealth program, or really quite far along. So you can see those teams listed. We had Pennsylvania, Wisconsin, Utah, Kansas, Vermont, Oregon, Rhode Island, and then Hawaii and American Samoa participated together as a team. Teams chose to either have a pre-hospital or a hospital focus. And like I mentioned, each with a very diverse, really diverse plans. Next screen, please, or next slide, please. So we had a lot of accomplishments in that very quick timeline. So I mentioned that we started on January 1st and we wrapped up on January 30th. So lots of challenges with that aggressive timeline, but again, kudos to the teams who really got a lot of work accomplished, each and every team who got a lot of work accomplished. Actually, I'll take a moment to pause and say you can actually check out one of our teams had a poster session, the Hero Kids registry from Oregon. And so many of you have probably had a chance to look at that poster. Going back to our accomplishments. So each team did complete an environmental scan to really see what existing resources were available in their region or state or territory. We went through a process with the advisory council of identifying 9 key drivers of telehealth. And we really had a wonderful opportunity to gather resources and build a very robust telehealth toolkit that is available and accessible on the EIIC website. Each team went through a learning process of identifying performance metrics. Dr. Macias gave a wonderful talk during one of our every 2-week learning sessions about quality improvement methodology in identifying or creating performance metrics for their projects. We had multiple targeted expert panel discussions that not only included subject matter experts in telehealth and telemedicine, but many of the resources across the country, from anywhere from telehealth, our telehealth centers of excellence that are already existing, to individual organizations who are also really vested stakeholders in telehealth telemedicine. Teams had the opportunity for increased networking, while acknowledging it was somewhat challenging in a large virtual platform to promote networking. Each of the teams did have quite a bit of opportunity to network among themselves and build some great relationships with their peers. At the end of the collaborative or learning session, or collaborative, I should say collaborative, we did acknowledge and identified measured improvement in 3 of the 9 key drivers: technology, access, and high quality of care. The table on your the bottom of your screen shows the initial phase. Dr. Remick mentioned really the phases of implementation in a collaborative. So you can see many of the teams started out in really from phase 2 to phase 4. And then each and every team had either stayed right at the same, because those teams were already very in depth in their telehealth projects, but each team did show some advancement. So we were quite excited about that. Next slide, please. And I think that is it. Turn it back to.
Thanks, Lisa. So just in these last 10 minutes, we just wanted to give you a brief overview of the quality improvement collaboratives that are coming down the pike, starting with the PEC Workforce Development Collaborative. We'll talk briefly about the Mental and Behavioral Health Collaborative coming up, the Pediatric Readiness Quality Collaborative, and then the Regional Pediatric Pandemic Network Collaboratives that, of which there will be many and very much aligned with the EMSC space. So next slide, please. So kicking off today, again, in just about 20 minutes, is our PEC Workforce Development Collaborative. And this really came out of a lesson learned from the Pediatric Readiness Quality Collaborative, where we found that many of the teams from the 130 hospitals who participated just really didn't have the level of foundational background in pediatric readiness, or best practices and how to implement some of the strategies that were needed to develop these quality improvement plans and processes. And we really wanted to spend time developing that workforce and bringing them into the fold so that they would be more ready and able to effectively implement pediatric readiness efforts. This collaborative has 4 tracks really based on the continuum of practitioners within the EMSC cycle. So pre-hospital practitioners, nurses, and other healthcare professionals in the emergency department setting, physicians and advanced practice providers, and then of course our state EMSC program managers. And really the goal here is how do we implement pediatric readiness, not what is pediatric readiness, but really being able to work with these individuals and support them to understand how best to implement these change strategies within their organization, and then to coach them through an individualized project. And that'll be phase 2. Our mental health collaborative will be kicking off shortly thereafter in the summer of 2022. And the goal of this collaborative, as you may have heard briefly about in the mental health plenary, is to really help participating emergency departments to develop a clinical care plan so that they're better able to meet the needs of children who present to their hospital with mental and/or behavioral health emergencies. There's some wonderful evidence base to support this, a wonderful joint policy statement led by Dr. Tom Chun and others, the Critical Crossroads Toolkit that came out of HRSA led by Laura Ludwig and many subject matter experts, and then the PEC toolkits that the knowledge management domain have really led with Mosa Dinajad, Mark Auerbach, and Corey Chimpatazzi. So really grateful to have those resources that will be used as the foundation for this collaborative and to help individuals drive this evidence base into practice. The focus will be on developing clinical care pathways that engage elements of triage, screening, assessment, and disposition. And for the more advanced teams, hopefully to be able to work even with the larger community of EMS agencies and other emergency departments to support them in implementation efforts. Go to the next slide. So our next collaborative is going to be the National PEDS Ready Quality Collaborative, and the National PEDS Ready Quality Initiative, which is a targeted issues grant, will really help to form some of the foundation for that collaborative that'll be kicking off in January of 2023. And the goal being to really operationalize pediatric readiness through quality improvement efforts on the front lines. So this is very similar to the Pediatric Readiness Quality Collaborative 1.0. But the difference here is that we'll be adding in some clinical care elements that will help participating EDs engage in particular clinical conditions and make improvements based on that. The foundation for this work comes from the last 2 years of efforts that engaged numerous stakeholder organizations, approximately 25 professional societies, federal partners, researchers, and other subject matter experts, to go through really a very robust Delphi process that expands upon our current pediatric emergency medicine quality metrics and integrates them into a tangible platform. If you go to the next slide. So this was really our goal, is to make sure that this work would be readily available for all types of emergency departments, those that have higher levels of resources, but also those that may not. And really the focus on those EDs where the majority of children are seen, where we know over 80% of children are seen in community EDs. So giving them an easily accessible platform to be able to measure and monitor their performance, making sure that it doesn't really require a strong background in quality improvement, but really simple and straightforward, that you get immediate feedback on performance and compare that to other sites that are similar to your own across a wide variety of ED settings. If you go to the next slide. What was most important with this effort is making sure that the areas of focus are very relevant to any emergency department. So as you heard earlier, we really work closely with researchers, subject matter experts, and current data, reviewing metrics that had already been predefined over 10 years ago by Alice Andrini and colleagues, and really building upon that given the large growth of evidence base within pediatric emergency care. And so the focus, similar to PRQC 1.0, of bringing in recognition and assessment and interfacility transfers that are really cross-cutting domains that affect all children presenting to the emergency department, but also some critical areas of focus like acute suicidality, head trauma, respiratory complaints, seizures, and a more exploratory pathway of vomiting. Next slide. There have been 28 measures that have now been defined and vetted through this whole process, as I mentioned, using NQF criteria and a modified Delphi process. We have identified critical elements for quality improvement efforts and benchmarking, and this work will be overseen through really a really wonderful privacy model, which is a patient safety organization model that allows for the sharing of quality improvement information across participating sites so that they really can learn from each other and grow in an aggregate way. Underway currently is finalizing the data management platform and beginning to pilot and field test this work, as well as to engage hospitals on the front lines to make sure that it'll work across diverse settings. Next slide. So that'll really be the crux of PRQC 2.0. However, this is different from NPRQI in that this is really an EIIC-led collaborative that has a very clear structural framework with ongoing coaching and well planned out plan, do, study, act cycles. So NPRQI is really a platform, and PRQC 2.0 is really a collaborative effort of bringing those sites together in a very structured mechanism similar to our other QI quality collaboratives. So our participants in that, as you saw, are mostly emergency departments, thanks, and we'll be able to move forward through that. If you go to the next slide, we're so excited that yesterday was the kickoff of the Regional Pediatric Pandemic Network, co-led by Charles Macias and Chris Newton out of UCSF. And they have just really brought together a robust team of experts across the country, 5 children's hospitals, including Norton Children's, Primary Children's in Utah, and Cardinal Glennon in St. Louis, Missouri, and collaboratively working with them and the EIIC and the Disaster Centers of Excellence. We're looking forward to kicking off a number of other quality collaboratives. That will include initially a disaster networking collaborative to really grow integration of the pediatric voice in our emergency management plans, the development and establishment of a second PEC Workforce Development Collaborative as we begin to grow our workforce and our community of pediatric champions, and then really rolling into a pediatric disaster response collaborative that really builds upon the work of the EAGLE Pediatric Disaster Quality Collaborative you just heard Meredith provide an overview of. And this will really focus on 6 core bundles related to disaster planning, reunification, integration of EDs and EMS, optimization of EDs, management of infectious diseases and pandemics, integration of the pediatric medical home, and the like, and then developing a pediatric coordinating center. So 6 bundles of opportunities. And then last, with all of that in mind, with a workforce in place and a pediatric voice and a wonderful group of individuals engaged in pediatric quality improvement efforts related to everyday readiness and disaster response, we'll be working to kick off a second pediatric medical recognition collaborative similar to the facility recognition collaborative to help to incentivize all of this work. So lots of great stuff coming, and I'm sorry, I think we're just a few minutes over. Our key takeaways are just that EIIC uses improvement sciences and collaboratives to drive evidence into practice in a more rapid cycle. Our collaboratives really do provide an opportunity for diverse regions, states to work together to improve pediatric emergency care. And we hope that overview provided some great opportunities for you all to join us in our future collaboratives. I don't know if we have a couple minutes to take any questions, but thanks.
Hey, I just wanted to make one comment, and that is that the EIC uses the model for improvement that was developed by the Associates for Process Improvement. Clearly, there are several different models out there that help support QI methodology, Lean, Six Sigma, et cetera. But we find this to be very easy. I'll put a link to where it was originally published, but I think it has become the foundation for many. I say that because I see a number of people that are involved in the IPSO collaborative. I see a number of people that are that have been involved in our substance collaboratives for the AP. So they may see some distinctions in both the phases of work and the models used.
Thanks for sharing that, Charles.
All right, everyone. So we are kicking off the PEC Workforce Development Collaborative. Everyone from the All-Grantee meeting is welcome to join. So we will see you all in about 10 minutes in that plenary. Thank you all so much.